Hello, everyone, and thank you for joining us. This is Nicole Giudice from the Health Policy Plus project. I'm delighted to welcome state-of-the-art in health financing reform, strengthening subnational public financial management. We'll begin with just a few announcements. The session is being recorded, and we will post the recording to the Health Policy Plus website. We're getting a high volume of traffic these days, as you know. We ask that you bear with us in case there are any glitches with the technology.
Thank you, Nicole. Meaningful progress towards universal health coverage requires countries to ensure sustainable and sufficient domestic public financing for the health sector. The increased emphasis on sustainable domestic resources in the achievement of universal health coverage has amplified the vital and fundamental nexus between PFM and health financing. While increasing revenue and domestic public resources for the health sector is key, countries must also make efficient use of available resources in the health sector through better alignment between budget planning and health sector priorities, and ensure that health resources are allocated and targeted more efficiently, and budgets are executed and managed as planned and in full. This requires improved financial management policies and practices that reprioritizes government budget in a way that increases government allocation of health within existing resources envelope so that more is obtained out of existing spending. This understanding has made PFM an integral part of enabling progress towards universal health coverage. PFM is key in optimizing not just how public funds for health are raised, but also how they are allocated, managed, and accounted for throughout the PFM system. HP Plus has been engaged in PFM reforms in several countries. We have seen it resulted in increased resources for health and essential services, including family planning, maternal health, and HIV. Our PFM work in health has focused on equipping ministries of health to effectively engage in constructive budgetary dialogue and coordination with ministries of finance, treasury to optimize fiscal space for health sector, increasing resource envelope through efficiency gains, sensitizing ministries of health on the importance of PFM in health sector planning and budgeting, including alignment of budget allocation with sector priorities, strategic and equitable allocation of resources, efficient execution of budget, and accountable and transparent budget monitoring, advancing equity and efficiency in allocation of resources at different levels, improving health budget absorption rates at both national and subnational levels through improved release and flow of funds and procurement reforms, providing reliable and timely information for Parliament, CSOs, and citizens for increased accountability and transparency. How PFM in health reforms pan out in practice, especially at local level, is extremely important in informing our understanding of what works and what does not work in a given context. To that end, HP Plus has organized this webinar to share experiences and explore opportunities for reform through two country case studies, Mozambique and Kenya. It is my honor to introduce Sanjeev Gupta. Sanjeev Gupta is a senior policy fellow with research interests in fiscal policy, aid, corruption, digitization of public finances, global health, and inequality. Previously, he was Deputy Director of the Fiscal Affairs Department of the International Monetary Fund, IMF, and has worked in its African and European departments. Prior to joining the IMF, Gupta was a fellow of the Kiel Institute of World Economics, Germany, professor in the Administrative Staff College of India, Hyderabad, and secretary of the Federation of Indian Chambers of Commerce and Industry. Gupta has co-authored over 200 papers, many of which are published in well-known academic journals, and has authored, co-authored, co-edited 13 books. Really impressive, Sanjeev.
Thank you, Sushmita. Good morning from Washington, D.C., and thank you very much for inviting me to speak at this important event and share my views on health financing. What I'm going to speak today is drawn from the work that I've done jointly with Ellen Broy of WHO. Next slide, please. When you look conceptually, and I think we heard this in the introduction, there are two ways to finance public spending on social sectors, including health. The first comprises raising domestic resources through taxation, or you can borrow money from within the country or outside the country, or you can rely on grants from external sources. That said, domestic taxation remains the dominant and the more sustainable source of financing public spending. The other way of expanding economy's spending base is through a better use of existing resources. And I think, again, this came out very well in the introduction. Here, practices and systems used by governments to manage budget resources become relevant. And this is the focus of this seminar. For example, effective spending procedures and financial information systems can expand availability of resources for the social sectors. While there are obvious links between the two concepts, improving expenditure management has typically not been seen as a way to expand the level of resources available to the health sector. So let me illustrate this point. So notwithstanding actual budget allocations for health, persistent bottlenecks in management of expenditure limit the size of health of the resource envelope in the health sector. And this is probably more in this sector than in other sectors. For example, if you look at the slide on the left-hand side, you see that the average execution rate of the health budget, not this slide, please, that's the previous slide. No, not this one, the next one. Yeah, this one, please, thank you. So you see the average execution rates for health budgets were about 85% between 2008 and 2016. So the money was allocated to the health sector, but on average, and this thing varies across countries. There are countries where the execution rate is substantially lower than 85%. Only 85% or less of the money was utilized. On the right-hand side, the figure shows for the same set of countries and for the same period, these rates are systematically lower. That is, the execution rate is higher. This reflects probably the peculiarities of health spending, where exact needs are not known at the beginning of the fiscal year, and it may require public financial management flexibility for full execution of the budget. Next slide, please. So this slide is taken from Burkina Faso, and so it shows how spending procedures can constrain access to and management of funds for health services. It's based on the budgetary regulations which prevail in that country. So, what the procedures are doing is they are constraining the effective management of expenditures by health service providers. It shows that there are multiple allocation and payment systems with their own spending rules, which create complexities in the resource use for providers. And that then in the end results in unused revenues for the health sector, limiting the provision of health services. Next slide, please. Against this background, let's now look at the overall fiscal space. The overall fiscal space in the economy is really a function of various macro considerations, such as economic growth, overall revenues, fiscal policies, current debt, size of contingent liabilities, access to capital markets, deficit rules, and monetary policy. That is the first block on the top of this slide. That's the overall fiscal space. So this influences the availability of resources for the health sector. And please note that I'm not using the term fiscal space for health, rather budget space for health. The budget space for health depends on the next three tiers that you see in the slide. It depends on the overall expenditure envelope for the economy, which is a function of the overall fiscal space, the budget allocation decisions, that is resources allocated to different sectors, including health, and finally, and importantly, the rules and practices on how the money which has been allocated is used, that is for public financial management. The added public financial management component is particularly relevant for the health sector in light of the evidence that I presented earlier on Burkina Faso, where I showed that PFM weaknesses can alter the availability of resources within the health sector. And PFM improvements can also influence future budget allocations. If the sector is able to execute budget fully and demonstrate an efficient use of resources, it may be able to secure a higher sector allocation in the future budgets. Next slide, please. So how can public financial management secure more money for health and health services? So one can see in terms of four main stages of the budget cycle, and the four boxes on the top that you see here in the slide, they capture those four key phases of budget formulation, budget approval, budget execution, and budget evaluation. In the interest of time, I will focus on budget formulation. In budget formulation, the use of line item allocations often limits reallocation across sectors and can result in low spending by the health sector. Using more flexible approaches, such as program or output-oriented approaches, is likely to enhance flexibility in the use of funds and thereby create potential for more and better spending. We learned during the COVID pandemic that countries that have flexible budget formulation, they were able to rapidly shift funds towards emergency response. And this was the case in South Africa, Mexico, and New Zealand. Next slide, please. So while PFM improvements are important, PFM improvements will not alone or not necessarily increase budget space for health. They don't necessarily automatically transform into more resources for health services. For example, several countries have introduced program budgets in health. What they have seen, their budget execution rates go down because of poor design and some complexities in spending procedures. In particular, they continue to have input-based controls for the release of funds when resources are planned by programs. It can significantly impact on the volume spending, as we saw in the case of Gabon recently. As countries define their PFM agenda for health, reform should be designed in a way that they can strengthen the basics. You can see that the point that is there on the bottom of the slide, while at the same time providing more resources and flexibility for service providers whose capacity for financial management and reporting should be strengthened to support accountability towards outputs. With this, I would like to stop. And my presentation is drawn for this couple of pieces that are linked here in case you would like to go to them. And thank you so much for taking the time to listen to me. Bye.
Thank you, Nicole. Good morning, good afternoon to everyone. I'm Rachika Chaudhary, Director of Health System Innovations at Palladium and the HP Plus lead for the Mozambique program. Today, we're going to hear about the first case study from Mozambique. Mozambique has been undergoing PFM reforms for some years. Many stakeholders are engaged in this, many line ministries, many development partners, and many other stakeholders at the national and regional levels in the country. HP Plus has been actively engaged in PFM and the program-based budgeting efforts that we will hear about today, and they are supporting both Ministry of Health and Ministry of Finance in these efforts. It is my pleasure to introduce three colleagues today who have been very engaged in these efforts. They will discuss Mozambique's PFM reforms, moving towards program-based budgeting, and the digital process that is very much part of this. I'll introduce them one at a time as they present. First and foremost, it is my privilege to welcome Dr. Antonio Moyovo. Dr. Moyovo is the National Director of Administration and Finance, DAF, in the Ministry of Health in Mozambique. DAF is responsible for the budget execution in the country. Dr. Moyovo has been leading efforts to improve the traceability of the budget execution by health programs. Together with the Directorate of Planning and Cooperation, DPC, Dr. Moyovo is advocating for the success of the new planning system, which we will hear about, and his work is oriented for results within the Ministry of Health. Welcome, Dr. Moyovo, and thank you for joining us today. Over to you. For Dr. Moyovo to connect, let us maybe begin with our next speaker also for the Mozambique program, and this is Salomão Lourenço. Salomão is an expert in PFM in Mozambique, and he has the key role of providing technical assistance to the Ministry of Health to leverage PFM functions. Salomão graduated in accounting and finance, and he works for HP Plus Thinkwell as a senior program manager in Maputo. He works closely with the government. Salomão will take us through the details of the PFM reforms underway currently. Welcome, Salomão.
In this presentation, I'm going to give a little bit of context of Mozambique planning and budgeting system, including the changes on the financial administration system as a result of the ongoing reform. I will focus on the work that the HP Plus project is doing in support of the planning and budgeting system, including some preliminary results. We'll also share some suggestions in terms of what additional work to be done to assure an effective implementation of PBB. And of course, we'll be happy to receive your questions at the end of all presentation. Next slide, please. In terms of context, Mozambique shares the same PFM challenges with many other low and middle income countries. specifically lack of alignment between planning instruments with budget execution. In most cases, expenditures cannot be tracked by programs. To attend to this situation in 2015, the Ministry of Finance initiated a reform of the current planning and budgeting system, bringing into light the new system, which is called Subsystem of Planning and Budgeting, generally known with the initials SPO. The government planning and budgeting system, the SPO, was approved last year by the Parliament and sets the key lines for the implementation of the program-based budgeting. The SPO, the system of planning and budgeting, consists in two main streams: the process and the digital part. The process is very much related to the architecture of the planning and budgeting system, the rules, procedures, and responsibility. And the key part of the line ministries, such as the Ministry of Health, was to set up program portfolios in line with the mandates, including a clear definition of objectives and setting up adequate key performance indicators. And also the digital part that has to do with the electronic system that supports the SPO, the subsystem of planning and budgeting. The HP Plus project is supporting the PFM functions in the Ministry of Health since 2016, but in 2019, this support was extended to the Ministry of Finance in order to get Ministry of Health needs prioritized in the ongoing reform. Next slide, please. Well, this diagram shows how the financial administration system of the government of Mozambique is structured after reforms. Essentially, the number of subsystems increased from 5 to 6 with addition of the subsystem of monitoring and evaluation. It comes in pink color. In blue color, we can see the subsystems of government administration system that were reviewed on the reforms, specifically the subsystem of planning and budgeting, that is the SPO, that was designed to pave the way for the program-based budgeting. And of course, its electronic module, which is called the SPO. Next slide, please. In terms of what motivated the HP Plus project to support the planning and budgeting system, the SPO, the HP Plus support to the Ministry of Health dates back to 2016. By that time, there was a significant effort of the HP Plus team to track expenditures against the activities of the operational plan and programs. I remember that in one of those attempts was found that more than 80% of expenditures, except drugs and health products, paid by domestic funds were allocated to general operating expenditures, even when related to specific health programs that have dedicated budget lines. This brought to light the need of improving the process of budget allocation across programs, and also needs of aligning strategic and operational plans with budget and budget execution, and also improve data quality for budget monitoring. At the time that the HP Plus was looking at possible alternatives to respond to Ministry of Health needs, the Ministry of Finance was discussing the implementation of the subsystem of planning and budgeting, the SPO, which offered a broader solution for the Ministry of Health needs, as it supplied not only for the Ministry of Health, but also for the subnational level. That's what triggered the interest of the HP Plus project to support the Ministry of Finance. And one of additional issues is that at the time, the Ministry of Finance was not able to move on with the reforms because of lack of resources to develop the electronic model of the SPO. Next slide, please. In terms of how the HP Plus is supporting the planning and budgeting system, again, the SPO, essentially the HP Plus is concentrating the efforts in supporting the Ministry of Health planning and budgeting process, because as I said, there are two main streams of the SPO, the planning and budgeting system. One is the process, and the other one is the electronic system. So the process, essentially the support of HP Plus is concentrated in the Ministry of Health and the system in the Ministry of Finance. So essentially in the Ministry of Health side, the HP Plus is supporting the preparation of program portfolio, including the clear definition of objectives and key performance indicators, and also engaging Ministry of Health and partners to adhere to the subsystem of planning and budgeting, which offers opportunity to improve internal processes in the Ministry of Health, of course, in terms of transparency, accountability, and so on. A significant piece of the HP Plus support to SPO is dedicated to the development of the MPO, the electronic model of the SPO, and was basically in the recruitment of skilled IT consultants, reviewing and adjusting requirements and other relevant documentation for the module, and also the development and testing of the electronic model of the SPO, and also providing some training, which contributes, of course, to the upskilling of the Ministry of Finance IT team. And also this support is expected to be extended to the implementation phase. Next slide, please. In terms of preliminary results of the HP Plus support, the planning, of course, in budgeting reform is still in the early stage, but there are some preliminary results that we can point on, such as Ministry of Health needs being prioritized in the reform. It takes part in all the different stages of the reforms, discusses and validates the program portfolio and the system functions. And one of the additional results is the partners getting involved and engaged with the SPO, although there is a need to involve many others, specifically the big donors. This is a long way to go, just to make sure that are all aligned in the implementation of this budgeting and planning and budgeting system. And one of the other results is the better preparedness of the Ministry of Health to implement the SPO, as it's taking part of all the stages, of course, and also the better alignment between the process, how the things must happen, and how the electronic system attends to those needs. One that we can also mention important is that the Ministry of Health end users are participating in the validation of the application that supports the SPO, and then the contribution for upskilling the IT team from the Ministry of Finance, which is very important for the continuity and sustainability. Next slide, please. We have some suggestions in terms of what more can be done. As I mentioned in the previous slides, in the implementation of the overall planning and budgeting system is still in the early stage, and the Ministry of Health will need assistance to continue its move toward effective implementation of PBB. I point some of the efforts that will have to be made or continue. One of those is the alignment of aligning strategic and operational plans based on the program portfolio. This is an effort that is expected to happen the coming year, as the Ministry of Finance is still preparing the whole processes of how this will have to be done, and assure that program portfolio is well known within the sector and all the relevant players, and also establish methodologies for accurate estimation of health program costs will be very important, and ensuring the correct prioritization across different sub-programs in the budget distribution, and also align budget allocation with expected performance. And of course, as the sector has a significant amount of budget projects, it's important to assure that progressively those are integrated in the national budget. In conclusion, the HP Plus project life will not, of course, cover all the relevant effort to effective PBB implementation, but I think that the country has been taking its own steps toward that. And with that said, thanks so much for your time. I will be able to receive your questions at the end. I will pass back the floor to Roshika. Thank you.
Our next presenter, Adriano Nahabanga. Adriano is the Development Assistance Specialist, Provincial Advisor at USAID, Mozambique. He has been a part of the Integrated Health Office Health System Strengthening Team since 2014. Prior to this, Adriano held many key positions in planning and finance. He worked for the Ministry of Planning and Development, Provincial Department of Planning and Finance of Zambezia, as the Planning M&E Officer in 2007. He was the head of the Planning and Budget Department thereafter, and he worked as advisor for Planning and Decentralized Finances for 4 years. Adriano has also worked as Planning Officer at the Ministry of Industry and Commerce, National Department of Economy, Department of Economic Analysis. He graduated in Business Management in 2005 from Eduardo Mondlane University. Welcome, Adriano. We look forward to your comments.
Thank you, Roshika, and good afternoon, everyone. Good morning. I will talk about the lessons learned in this process of PFM in Mozambique, specifically regarding to the program-based budgeting. Implementing program-based budgeting is not a one-shot effort. It's a long-term process that needs a clear definition of the different stages, which includes definition of the needed resources, well planning of the interventions, training of key actors, etc. So each upcoming budget cycle is an opportunity for learning. Second lesson that we want to emphasize is that clear understanding and appropriation of the program-based budgeting process by the key actors is critical, including the involvement or early involvement of line ministries in the early stage of the program-based budgeting, which contributes to reduce bias. The third lesson is that IT system requirements must be discussed with the stakeholders prior to the development of the application, allowing a better alignment between the process and the supporting electronic module. And lastly, coordination. So coordination is key because we have several stakeholders that are involved in this process of program-based budgeting process. So it's important to coordinate with all the stakeholders to make sure that everyone in the same page and understands the importance and the objectives of this reform to ensure that all of the stakeholders work together towards the intended results. With that said, I say thank you for this opportunity. Rokita, it's back to you. Thank you.
Okay, we will move on to the Kenya panel for now, and hopefully we will be able to come back and listen to this last speaker on the panel. So I'd like to introduce David Hoya from HP Plus and Palladium to introduce our Kenya panel. Over to you, David.
Okay, thank you, Nicole. And I want to introduce the panel that will talk about the Kenyan story. So the first one is Andrew Rory, the Deputy Director at Kenya School of Government. It will be followed by Dr. Khadija Shikeri, Chief Officer of Health, Mombasa County. And lastly, it will be Mr. Dim Nzoya Munguti of the USAID mission in Kenya. Next slide, please. So we will be talking about strengthening subnational public financial management in Kenya. Next slide. So just to give the context of Kenya, in 2010, Kenya promulgated a new constitution, which was implemented starting in the year 2013 with the Public Financial Management Act developed in 2012 to manage the financial spending during the implementation of the new constitution. The challenges that were there and some have persisted are basically lack of linkage between planning, budgeting, and execution of resources. We also had limited knowledge and capacity in PFM processes, as well as lack of capacity at the county level in planning and budgeting for health. The integrated financial management information system also did not fully integrate with other PFM systems. So to address these challenges, next slide, please. HP Plus, through a three-pronged approach of capacity building, supporting evidence generation and use, as well as supporting budget advocacy for the government and subnational level, ended up with several results, actually very many results. But today, allow me just to focus on the results that we obtained as a result of support in capacity building. We managed to train 764 people in 26 out of 47 counties in program-based budgeting. So this critical mass of people are distributed in these 26 counties, and some, of course, have managed to move to other counties, and they participate in planning and budgeting in those counties. Next slide, please. So As a result of our intervention in 9 focus counties, which we later called the deep dive counties, we ended up with $5.2 million committed in the financial year 2020-2021 in 7 of those 9 countries to improve maternal and child health, which was actually 41% increase from the previous year. These deep dive counties also increased allocation to HIV interventions from $165,000 in 2017-18 to $239,000 in 2019-20. The budget absorption also increased substantially from 79 to 88% in 2017. The deep dive counties also reduced out-of-pocket spending from 34 to 26, and this you will learn later from my fellow colleagues who will present how this was done. The personnel emoluments expenditure as a proportion of recurrent budget reduced also from 75 to 73%, allowing extra resources that could be utilized into providing other inputs. Next slide, please. So going forward, and what we are doing currently is to approach it in a multi-sectoral coordination where we are involving other stakeholders, especially the Kenya School of Government and other think tanks, to be able to strengthen the public sector. We have also tried working on establishing county planning units that will coordinate planning functions in the departments of health, especially at the county level. There are other approaches which we are following, including institutionalizing evidence generation and use, and as well as harmonizing planning tools that can then address the issues that we raised at the beginning. Next slide, and maybe this is my final slide. I want to welcome Andrew Rory to take us through the collaborations we had between HP Plus and the Kenya School of Government. Thank you.
Thank you so much, Dr. David. Happy to continue from where my colleague has left next. So in an effort to meet the constitutional and the PFM requirements in Kenya, which Dr. David has amply explained, it became apparent that a lot of capacity building for the officers working in both national and the county governments had to be done. Health function is one of the functions which were devolved in Kenya, and the county staff required a lot of capacity building to conceptualize the reforms and effectively participate in the realization of the goals of devolution. This because all programs in the lower level and national level government included in the budget were required to have clear objectives, outcomes, outputs, and with clear performance indicators. So in a nutshell, there was a major shift and orientation in the PFM budgeting system was necessary. A number of development partners, our agencies, embarked on a mission, and this mission was basically to enhance the proficiency of county personnel, and more specifically the health personnel involved in budget preparation in some select counties. While these entities carried out their initiatives independently, HP Plus deliberately partnered with Kenya School of Government to ensure the capacity building initiatives were sustainable and more impactful way beyond the initial training and support to the counties. By partnering with KSG, HP Plus leveraged on the capacity of Kenya School of Government to reach a wider range of institutions and public officers. And being a government MDIA, KSG is mandated to provide training, consultants, and research services designed to inform public policy, promote national development and standards of competence and integrity in the public service. So this explains why the partnership between KSG and HP Plus was quite crucial in terms of developing the capacity of the public officers. HP Plus and KSG activities involved development of a curriculum, which was basically focused on program-based budgeting. And this involved development of appropriate training modules, training manual, training materials, that is the presentation notes and slides. The 5-day curriculum focused on 5 modules, and this was planning for the health sector, the overview of public sector budgeting, medium-term expenditure framework, and the program-based budgeting, and lastly, costing of healthcare services with a bias towards activity-based costing. The school conducted training of trainers for the partners in readiness for the rollout and a series of massive training in the selected counties across the country. Delivery of the training was done through lectures, case studies, practicum, and group work, and evaluation of the training and certification was done by the school, and follow-up support during actual budget preparation was offered by Health Plus, and the initiatives between HP Plus and KSG have had an immense impact in the realization of the devolution, and indeed, health was the first sector to move to program-based budgeting. Next. KSG has continued to support all the national agencies and the county governments by implementing annual planned activities to address the capacity gaps through guidelines and manual dissemination. And this is very critical in terms of ensuring that we continuously engage with the counties over and above the classroom training, which is the structured learning, knowledge sharing, which is support collaboration with other counties, thematic peer learning meetings, and basically training of counties to be able to share experiences, technical assistance in terms of on-job consultation, system development, that is consultants on systems rollout and implementation, especially the whole process of planning and budgeting, and also providing a repository for good practices. Next. The capacity building of health personnel in the county is aligned to the budgeting cycle or the calendar in the country, and this one entails prioritization and determining resource envelopes, which is the entire budget preparation, the preparation of budget estimates, and that is up to the getting the actual figures, and this one involves costing of the various activities done. The legislative approval of budget estimates, where HP Plus and KSG has brought together the county assemblies, which is the legislative arm, and the executive in creating an understanding and a smooth budgetary process, and also finally looking and discussing with the counties on budget execution and monitoring. So in conclusion, what we are looking at is that the capacity building in the counties turned out to be a great success that has actually indeed motivated a number of other development parties and national agencies to pool resources to engage the school to assist in capacity building. Based on the numbers we have there, 764 of the officers from other departments in the counties over and above that. Holding other factors constant, as a school we can say the proficiency of officers in the health departments across all counties is much higher than those of other departments. This is courtesy of the capacity building carried out by HP Plus and the Kenya School of Government. And we look forward to continuously offering this training as envisaged in our agreement with HP Plus. Next. I now take this time to introduce my colleague, Dr. Shikeri, to continue the presentation. Thank you so much.
Okay. So Mombasa County is one of the deep dive counties that David has talked about, and through technical assistance on PBB and advocacy through, to the county leadership, Mombasa County, next slide please. Mombasa County has had remarkable progress in prioritizing health, increasing government funding, and increasing health insurance coverage by the poor and vulnerable populations of our county. We have made some strategic shifts in our health financing through increased government investment and steady decrease in donor funding. I think you can see from the slide that we have actually had government funding is increasingly making up a larger proportion of funding for health in Mombasa County. We have moved from a low of 15% to a high of 33%. Secondly, the county has also taken a deliberate approach to subsidize vulnerable population access to health through the health insurance coverage. And this was through a policy decision. As a result, we have actually managed to increase health insurance coverage to 21% in the year 2018, and with a national coverage of 19.9%. Next slide. While Mombasa County has steadily increased its allocation to health, we also ensure that efficient allocation absorption of available funds has also been a priority for the county. We have had serious bottlenecks in executing health budgets in the county, mainly stemming from delays in budget allocation or budget releases from the National Treasury and delays in procurement. So over the past few years, Mombasa County has strengthened its health budget absorption rates, and we have come from a low of 84% to a high of 97% in the years that you can see on the slide. Using the data generated and linking planning, budgeting with health sector priorities, Mombasa County has also managed to show progress in efficient allocation of its health resources by optimizing its personnel budget and freeing up resources to be allocated to other key budget inputs. I think you can see that we have actually reduced our personnel budget from 80% to 71%. And this 9% has actually been allocated or reallocated to operations and maintenance, training services, and purchase of drugs and non-pharmaceuticals. In the personnel emoluments, we actually found two amongst others was actually outsourcing non-core functions, that is like cleaning and security services, and that reduced our personnel budget, and also training of our young medical officers to be specialists instead of employing specialists from outside. Next slide. So what's next to build up on achievements that we have achieved in Mombasa County? One is raising domestic revenue. The other one is exploring revenue options, elevating health within fiscal space and budgetary dialogue within the county, and also taking a leading role in mobilizing resources for strategic programs. I think we can look locally with our stakeholders. We have a lot of philanthropists and private sector that are ready to work with us. We will need to increase further the insurance coverage for our county population, and also strengthen the absorption rate, and most of all, also strengthen supply chain management. These achievements were actually attained through technical assistance from HP Plus and sustained advocacy with the county leadership, including the county assembly, on the need to allocate more resources to health, formulating a social protection policy and development of a framework to support payment of insurance for the poor and vulnerable in the county population. We truly appreciate HP Plus for having made Mombasa one of the deep dive countries. Asante sana. Thank you.
Thank you so much, David, and good evening and good morning. My name is Zoya Munguti. As David has mentioned, I'm working with the USAID Kenya and East Africa in the health office and supporting healthcare financing. Our support to the government of Kenya is anchored on youth policy framework on foreign assistance and the country development cooperation strategy, whose goal, the goal of the mission, USAID vision on foreign assistance is basically to eliminate the need for these foreign assistance in the future. This tough, but the vision is quite ambitious and possible by a new strategic approach where USAID role is basically to catalyze development process as opposed to financing. And that's why we've had engagement with the Kenya School of Government to to capacity build counties in planning and budgeting. So to this point, USAID through HP Plus is our lead health financing partner, We support the national government and PEFA-focused counties to promote domestic resource mobilization for health from both public and private sectors, basically to enhance sustainable financing of healthcare services, including priority core strategic programs like HIV, TB, malaria, and reproductive health. So the strategy that we are using to advance our vision on foreign assistance is basically the journey to self-reliance, and basically talks about financing self-reliance. To this point, and toward the realization of USAID our vision, we support engagements with the public and private sectors in planning and budgeting. A case in point is our collaboration with the Kenya School of Government, where we leverage on the capacities to strengthen county capacities in planning and budgeting. So our engagement mainly focus on building skills and past knowledge to government institutions at both national and county level. And this is mainly about strengthening the capacity of counties in planning and budgeting, focusing on program-based budgeting. We're also focusing on evidence generation, mainly to inform health financing reforms across the 3 health financing functions. And those, so basically the evidence that we generate will informs planning and budgeting, and also policy dialogue around health financing. To that point, we have been working with the Kenya School government, and will continue working with this as one of the public institutions to make the development process self-sustaining. As mentioned at the beginning, our role is to catalyze development. So we'll continue working with the Kenya School of Government and other local organizations, so that we can realize our journey to self-reliance. I will pause there. Thank you so much. Over to you, Chair.
Thank you, Nzoia, and thank you for this wonderful panel. Thank you again for your wonderful presentations from this illustrious panel of speakers. We have a few questions today. I'll start out by asking a question to the full panel, and please, if any of you wish to respond to this question. We've heard about transparency in allocation and expenditure of funds, and how that's been a challenge in the health sector. And today we've heard examples of how PFM reforms have improved transparency. What additional steps do you see your countries taking to increase transparency of this information and demonstrate accountability to citizens by ensuring resources are spent as intended? And I'd like to invite the panel to switch on your cameras if you're able, if your connection will allow, so that we can see your faces. Yes, please, Mr. Nzoia.
Nicole, thank you so much for that question. I think for us, one of the issues that we've been facing is the low budget execution. Although there has been some improvement, and that is tied to the disconnect between our program-based budgeting and our integrated financial management system. The two of them are not speaking to each other, and therefore, when it comes to budget execution, it becomes a challenge. So our moving forward, I think we want to work with the relevant government institutions to make sure that the PBB formats, the PBB is linked to the integrated financial management system. It therefore becomes very easy to monitor budget execution. Thank you, and over.
Thank you, Mr. Nzoya. I'd like to invite a speaker from the Mozambique panel.
Yes, thank you, Nicole.
To give your perspective.
Yes. I think that for Mozambique, the program-based budgeting will allow the alignment between the allocation of funding and also with the sector priorities, which will facilitate the dialogue between the government and the and other stakeholders, because it improves the transparency, because it's easier to see where the funding is being allocated, and also to link the results with the funding. So we are real hoping that with this program budgeting, based budgeting will improve transparency and the linkage between the priorities and the funding. Thank you.
You can go to the next question, Mustafa.
And so if you don't have anything to add, I'll move to the second question. I have a question for Dr. Shikeri. Dr. Shikeri, you talked about allocations and the improvements on not only just investment, but also efficiency of resource use. So a question for you is that if the national government procures commodities, for example, how are you using funds allocated to the disease programs at the county level?
Thank you. The national government only procures commodities for core programs. Example, for HIV, they procure ARVs. For malaria, they procure antimalarials and TB. But at the county level, the counties use their money to buy, we use our money to buy essential medical supplies in support of disease management, and also preventive activities for surveillance, for monitoring and evaluation, and for facility operations. So we do not use the monies to procure those commodities because they come from the national government, but that's all they give us. So we have to use our monies for other activities. Yeah. Thank you.
Thank you, Dr. Shikeri. I have a question for the Mozambique panel. We talked about the new SPO system. In what ways is the new SPO system going to strengthen coordination and budgetary dialogue between MOF, MOH, and other involved stakeholders?
Thank you. Thank you, Mustafa, for the question. I think that, as you know, SPO is going to allow the budget allocation by program areas. And also, it will facilitate the execution tracking by programs. And also, as I said in my first intervention, it will increase transparency. So it will facilitate the dialogue between MOH, Ministry of Finance, and other stakeholders in the sense that we can clearly show where the money is allocated, looking to the priorities of the health sector. So it's easier to discuss with the Ministry of Finance, showing how the money will be used and how it will contribute to improve the results in the health sector. So that's how it will facilitate this dialogue, as well as with other stakeholders such as donors and other implementing partners in health sector. So this DSPO has this will allow this dialogue between all the stakeholders in the health sector. Thank you.
Thank you, Adriana, for the answer. I have another question for Dr. Rory. Dr. Rory, KSG has a unique perspective on the government's needs and demands for capacity strengthening, right? So what types of topics and skills are most in demand these days? What do you see as an emerging capacity need for counties?
Thank you so much, Mustafa. Well, this is usually a very dynamic environment because of the human resource turnover. And so as the counties keep on going through a number of cycles, sometimes we get especially the top officials involved in the county management. They end up being basically replaced. But nevertheless, over the time, the topics which have continuously featured have to do with things like the financial management skills, the planning skills, the budgeting skills. And of late, there's been a lot of issues to touch on governance and ethics aspects. But when you look at the emerging capacity needs, and this one also follows what Zoya was talking about earlier, the element of absorption. And that means that we may have to look at a way of linking procurement to budgeting processes to ensure that absorption levels are enhanced. Also, the element of policy formulation and implementation, because some policies which do exist within our national, subnational government sometimes may not really support the realization of the objectives. And also the element of performance management aspects and being able to demonstrate accountability for the resources allocated to the government agencies. Thank you.
Thank you, Dr. Rory, and I appreciate the answer to that question. I also want to make sure that we don't miss any questions coming in from participants. So I wonder if there are any questions coming in so that I can ask the panelists. I think we have a question from Damiano. The question is that I wonder whether alongside accountability, we can consider how and to what extent PFM is seen as a set of tools available to the public sector manager to ease the production of services. This is a general question to the panelists. So anyone from the panel who would like to tackle that?
Maybe I can be able to comment on that because when we look at the PFM, and I do appreciate the aspect of accountability, but going ahead, I think what Damiano is asking is that how do we use this PFM as a tool basically to ease the production of services? Because the whole thing is that what is the efficiency and effectiveness levels in the PFM processes. So if you work around the PFM processes and look at how efficient we are in the basically prioritization of the various programs and projects of the government, how we allocate resources efficiently around those programs and processes, and then being able to demonstrate that there are results, that's outputs and outcomes from the use of those resources, then the PFM becomes an enabler in terms of the production of services in the public sector. So we have to look at the processes and see how do we ensure the levels of efficiency and effectiveness are enhanced through the processes. Thank you.
Thank you, Dr. Rory, for the response. Move to another question that came up from Shem. I think it's a comment, but maybe panelists can comment on that. Is the role of private sector in contributing to domestic resource mobilization and strengthening the PFM Act has not come out clearly, but I think she appreciates Dr. Shikeri made a reference to the private sector. So, Dr. Shikeri, would you like to expand on that a little bit?
Yes. Okay. For us at the Department of Health, we do conduct stakeholders forums that we bring in a lot of corporates and private firms to come and see what we do. We even take them to our facilities. And I can mention a few that have worked with us. One is a cement company, Bamburi Cement, who have actually, there was a house, an old house at the referral hospital, and they've converted that into an oncology center. And they've donated everything with the equipments and the chemotherapy chairs and all. And the other one is a Safaricom, which is our big telecommunication company, which has actually put in an 8-bed HDU unit in the maternity wing, because usually when we have any problems in the maternity unit, it actually has to go to the main high dependency unit or ICU. But they actually made one specific for them, and many more. We've got companies that have come in to do dialysis renal centers and buying dialysis units. So there's a lot in the private sector that they can actually help us, but we just need to bring them forward and to show them what we do. I think they just need confidence that we are there, and they know that the monies are never enough, and they are ready to help. So long as we really bring them in. Yeah, thank you.
Maybe Mustafa, I just add something quickly on what Dr. Shikeri has said. Actually, through our engagement with the counties and the support we provided in evidence generation, the counties have now appreciated the role of private sector in terms of financing health. And because of that, they now involve them in the planning process for health provision. And that has really improved the working relations and the support that they get from the private sector. Over. Thank you.
Thank you, David, and thank you, Dr. Shikeri. Speaking of evidence generation, I have another question for both panelists from both countries. I think there's a lot of focus on ensuring that there are systems in place, tools in place to generate data and information for decision making. Will you tell us more about the steps that counties and national governments can take to ensure that these data are used? I think most often that becomes a challenge where data is there, but then the use of it and how to use it, the analysis of it in country at the national, but also at the local level becomes a bottleneck. So how do you ensure that these systems that do generate data, these data at the end of the day is used to inform decision making?
Maybe I go first.
Please.
Yeah, so the evidence we have supported in generating has actually provided a lot of information, including information around the out-of-pocket spending. And this has actually made counties to deliberately come up with policies to deal with that issue. As Dr. Shikeri had mentioned earlier, that evidence showed that households are paying a lot of money, and therefore the county decided to actually support them to pay for their national hospital insurance and also stock commodities in the facilities, so that because those are the drivers for the out-of-pocket spending. So through stocking, the clients are now able to get the medicine and actually reduce the out-of-pocket spending. Over, maybe my other panelists can add something.
Maybe Mustafa, if you can allow me to add something on the private sector. Yes, good question. I think for the the private sector contribution to domestic resource mobilization. Looking at the bigger picture from the USAID side, we are looking at, we know that the private sector has capacity both to finance and provide health services, but then the policy environment in most of our countries, the regulation issues are very weak, and there are issues to do with standards and quality and standards. Those are some of the barriers that at a higher level we are engaging with the government so that we can facilitate their participation in contributing to domestic resource mobilization. There are so many issues with access to capital. So the whole idea is we want to engage so that we can expand private sector opportunities in health development. So there are quite a number of policy, legal, and quality and regulatory issues that needs to be addressed so that the private sector can contribute to DRM. Thank you.
Thank you, Nzo. I appreciate you taking that question that we asked earlier. I appreciate the insights.
Okay, well, thank you, everyone, and thank you, Mustafa, for stepping in. I hope everyone can hear me clearly now. We want to thank the expert panel from Mozambique and Kenya for joining us today, and a big thank you to Sanjeev Gupta from the Center for Global Development. We really enjoyed learning about the progress being made in Mozambique and Kenya and lessons learned so far in strengthening PFM. I'm Director of Administration and Finance in the Mozambique Ministry of Health. Unfortunately, some technical difficulties prevented him from being able to speak today. But we appreciate his willingness to join and preparedness to make those remarks. Thank you again for the questions that have come in. This session is being recorded, and we will share the recording with participants. Have a good day and a good evening to our colleagues. Thank you.
Thank you.
Thank you.
Thank you.